Good afternoon to all of you. Today, we are going to talk on blistering diseases and pigmentary disorders. Now, actually, these two sections are very vast areas, but I think I have touched them to the possible level where we can discuss during 1 hour. So first, we will discuss about blistering diseases. Blister is a fluid-filled cavity. When it is less than 5 millimeter, we call it a vesicle. Then if it is larger, we can call it bulla, or when it is many, we can call them bulli. All blisters may be seen as erosions on the skin because when they break off, what is left is the flow of the blister only. So then that will lead to exudation and cast formation. So before we go into details of a blister, just to sort of recall your memory regarding the layers of the skin, it contains epidermis and the dermis connected or bound to each other with basement membrane zone. So any damage occurring in these areas can cause blistering. So when we magnify the area, like in the basement membrane area, where we get the basement membrane and the epidermis and the dermis below them. So these are the structures which we can find, and the important ones depicted in picture form. So we get the keratinocytes, which are joined by desmosomes. So desmosomes have intracellular plaques and binding proteins between the cells. And hemidesmosomes are the ones which bind keratinocytes to the basement membrane. And the basement membrane again is bound to the dermis with different types of collagen. You can see that type 1 and sometimes type 3 collagen is found in the dermis, and it is bound binding the basement membrane with anchoring fibrils or type 7 collagen. So there are different types of collagen here and etc. So there are, other than collagen, there are different proteins. So the importance of knowing this is any damage. It may be a genetic damage, or genetic defect, and or autoimmune damage, where the autoantibodies come and damage these proteins, which will give rise to a blistering disease. So there are so many blistering disease. There are so many etiological causes for a blister on the skin. All of you must have had a blister on your skin, maybe after a burn, maybe after infection, etc. But in dermatology, we have two major disease groups called blistering diseases. So for a blister following a burn, the etiology is different, but these two groups are due to either damage of one of these proteins. In immunobullous disease, we get autoantibodies, autoimmune damage to the structures. In mechanobullous disease, what you get is a mechanical defect due to a genetic defect in the person. So this is a very crowded slide showing most of the major groups of autoimmune blistering diseases. This slide can be used by you to compare each other, the groups. And importantly, the important ones are bullous pemphigoid, then dermatitis herpetiformis, and pemphigus group. So now you can see bullous pemphigoid has other common variants, but there are so many other variants if you go into depth. Circuit racial pemphigoid, childhood bullous pemphigoid, etc. So they are highlighted in blue color, and pemphigus group has certain other variants, and dermatitis herpetiformis is somewhat less common condition. So I think you can leisurely go through this slide when you are studying to compare each other about these disease entities. There are other conditions. They are not considered as blistering diseases, but dermatological diseases which may have blisters. For example, bullous lichen planus. In lichen planus, again, the basal cells are damaged in the epidermis, and so that can lead to a blister. And in lichen sclerosis, then lupus erythematosus, where again the basal layer is damaged, can give rise to blisters. So they are not blistering diseases as per se, but they can cause blisters. So we will talk a few things about bullous genodermatosis. Now, bullous genodermatosis. Genodermatosis are where the dermatological disease is due to some genetic damage. So in the group of genodermatosis, there are certain conditions which can give rise to blistering. So all of them don't come under the blistering diseases or mechanobullous diseases, but epidermolysis bullosa is the umbrella term which we use for these mechanobullous diseases. So there are various types, usually onset at birth or early childhood. But there are other genodermatosis which can give rise to blistering. So mastocytosis, I mean, just for your knowledge, so you may see them or you may not see if you don't work in a dermatology unit. But better to understand that there are certain rare diseases sometimes which may present to any practicing clinician, any doctor. So mastocytosis due to collection of mast cells, Hailey or familial because there is a defect in the cell adhesion to each other in the keratinocytes, and porphyria cutanea where there is photosensitive blistering due to the increased porphyria. So we will move on to the major three groups: bullous pemphigoid, pemphigus vulgaris, and dermatitis herpetiformis to talk in detail. Bullous pemphigoid is causing subepidermal blistering. That is under the epidermis. Subepidermal blistering. The split is between the epidermis and the dermis. So it equally occurs in males and female. There are HLA association. So some people are genetically predisposed to develop the disease, and more prevalent in elderly. So pemphigoid patients are generally elderly patients. So a drug, an injury or skin infection can trigger the onset of disease. So actually now patients don't come saying that I have bullous pemphigoid. So you have to know about the features, say what is common in elderly, what is common in there is a genetic background, what can follow after certain drugs, etc. And then when there is a patient in front of you, you have to decide what the diagnosis is. So it is important to know these features to differentiate at the initial step of diagnosis. So in bullous pemphigoid, the target protein is bullous pemphigoid antigen 180 or 230. So they are located in the hemidesmosomes. I showed you a few minutes back. They attack on basement membrane with IgG or IgE antibodies and also T lymphocytes due to misfiring of the immune system. So these antibodies will release various cytokines and cause damage to these molecules and recruit neutrophils to the site. And in the histology, we may see neutrophils and destroy the hemidesmosomes, forming. So when the binding structure is damage, the cells will separate from the basement membrane, causing a subepidermal blister. So it is usually itchy in bullous pemphigoid compared to the pemphigus vulgaris, which is generally non-itchy. Large, tense bully. Now, we have the whole epidermis on top of the blister. So it is tense. So it is tense because there is one whole epidermis on the top of the blister. So it can rupture, and sometimes these patients will have non-specific rash. Sometimes they can have urticaria-like hives, urticaria-like lesions, which later on become blisters. Sometimes mistaken as some other dermatological condition before the full-blown disease appears. So there may be ring-shaped lesions, sometimes smaller vesicles may be there, sometimes there may be very large lesions. The blisters and itchy nodules can be there. Usually these blisters contain clear or yellowish fluid, but it can be blood stained. We call it hemorrhagic blisters because the dermis is exposed so that the blood can leak out. So when they heal, there may be cross-inflammatory pigmentation. So some of the areas may show healed lesions with this pigmentation. Milia. Milia is retained keratin. So milia occurs when the blister is subepidermal. So that is another feature where we can assume that this blister is subepidermal. If there are milia, milia look like tiny whitish papules, tiny whitish papules. So sometimes pemphigoid may be localized to one area, or generally we see widespread on the trunk and proximal part of the limbs. Usually it doesn't involve the mouth and genitalia. This is an example. Here you can see intact tense blisters. And this is where it is broken and you can see the erosion, so you can see the underlying surface of the dermis. And so it's in an elderly person. And here again, you can see urticaria-like lesions. Now, if you see this lesion only, you may think it is the urticarial hive, but here you can see urticarial lesion as well as broken blister. Here you can see a lesion without urticaria in the background. Here you can see, this is the clear fluid is there, but here you can see that it contains hemorrhagic fluid, so red color lesions. These are old lesions healing. So the diagnosis. Now, clinically we have to suspect. So initially they come to us and the biopsies, immunofluorescence and those things take time. So initially clinically we have to suspect depending on the clinical features. Then confirmed by skin biopsy, sent for histology, and also which will show a dermal neutrophilic infiltrate, and eosinophils may be prominent, and immunofluorescence, where there are fluorescent material which attach IgG is added to the sample and looked under the electron microscope to see that the particular area is highlighted and fluorescent. That is called immunofluorescence. So it is looked under the immunofluorescence microscope, and so the deposits will lie along the basement membrane. So not in the epidermis, not below the basement membrane. It is along the basement membrane. So those are available for us. Immunofluorescence can be done in MRI in Sri Lanka. A blood test including indirect immunofluorescence test for the circulating antibodies is not available here in Sri Lanka, but that is another possible investigation. So how to treat? Basic steps. If the lesions are few and not very aggressive, we can use ultrapotent topical steroids like clobresol, propionate topically alone. Then emollients will relieve itch and dryness. Usually we start systemic steroids to get it under control. Then sometimes we add steroid-sparing medications like cyclophosphamide, azathioprine, mycophenolate mofetil, etc. And we should consider pain relief. So dose of prednisolone is slowly reduced over months or years, but it is a long-term disease. And sometimes we can use these adjuvant therapies like doxycycline, tetracycline group of drugs with nicotinamide. So they act as some anti-dapsone and the other immunosuppressives I mentioned before. And intravenous immunoglobulin. You know, intravenous immunoglobulins are extracted immunoglobulins against certain antibodies. So these antibodies are neutralized by giving intravenous immunoglobulin. Rituximab is a biologic which targets B cells. So when B cells are producing and when the B cells are damaged or killed or made them to apoptose, gradually the antibody formation will subside and the patient will recover. So when patients are on long-term steroids, we need to use certain other drugs like the proton pump inhibitors, sometimes bisphosphonates to control the side effects of steroids. So now we will move on to pemphigus vulgaris. So in pemphigus vulgaris, there is damage to sort of desmosomes causing intraepidermal blistering. So hope you can remember the desmosomes are the cell bonds which are binding two keratinocytes to each other. So pemphigus affects people of all races, age, and sex, but in South Asian region, pemphigus is commoner. In Western countries, bullous pemphigoid is common as blistering disease, but in our region, it is pemphigus vulgaris. Vulgaris is the common form. It's more common in middle age, so not in elderly like pemphigoid. So IgG autoantibodies bind to desmoglein 3, which is found in desmosomes, and keratinocytes separate from each other. And so in the blister, there will be separated keratinocytes and the serous fluid. So this IgG is found, the desmogleins are found in mucous membranes as well. So they will present commonly with mucosal involvement compared to bullous pemphigoid. Sometimes the mucosal lesions are predominant over the initial several months, or it may be the initial manifestation when they come to you. So the lesions are flaccid because only few epidermal cells will be in the roof of the blister. So it is intraepidermal, so that is inside the epidermis. So it will be flaccid blisters and it will rupture, causing painful erosion. Sometimes there may be vegetative, like growth like lesion in the flexures, then we call it pemphigus vegetans. Here you can see this patients, the oral mucosal involvement, including the lip, eroded areas, and here on the skin you can see that large areas of erosion. Usually only few blisters will be intact because they are easily broken off due to the thin roof of the blister. So again, we can perform skin biopsy, which will show the acantholytic cells, that is, keratinocytes, when they are separated from the surrounding desmosomes, they appear like round cells. There will be suprabasal clefting. So the cleft will be just above the basement membrane zone and confirmed by direct immunofluorescence. And so circulating antibodies can be detected by a blood test, but again, not available in Sri Lanka. Now here is a picture of immunofluorescence. You can see the dermis here, and this is the epidermis. So keratinocytes are demonstrated in red. And this is the wavy area as the basement membrane. And this greenish material is the fluorescent IgG antibodies. So IgG antibodies are attached with a fluorescent material. So it is visible in the immunofluorescent microscope. So this called chicken wire appearance, and that confirms the damages between the epidermal cells. So pemphigus vulgaris, suprabasal, just above the basement membrane zone. So treatment. This is a severe disease which can be lethal if untreated. So we have to treat more aggressively than pemphigoid. So we go for intravenous or oral steroids. Sometimes we give high dose of dexamethasone, 100 milligrams 3 days every month with IV cyclophosphamide. So that is called DCP pulse. And we may combine it with oral cyclophosphamide, azathioprine, dapsone, etc., microphenolate, etc. And again, intravenous immunoglobulin can be given as monthly pulses to neutralize the antibodies. Then rituximab is used in pemphigus also with good results. The only problem is it is not easily available because of its cost. Then we will move on to dermatitis herpetiformis. It's comparatively rare compared to the two conditions we discussed already. Persistent immunobullous disease that has been linked to celiac disease, a gluten-sensitive enteropathy. So affect predominantly middle-aged, more in, there is a 2-to-1 male to female ratio. So there is genetic predisposition, certain HLAs are associated with dermatitis herpetiformis, and some patients have a personal or family history of other autoimmune disorders. There, the IgA antibody is the main agent which will target the particular antigen and cause the disease. So IgA will be deposited compared to the IgG in pemphigoid and pemphigus. So that again can be demonstrated with immunofluorescence. So generally symmetrically distributed or scalp and also the extensor areas. So this is mainly the extensor areas. They are again extremely itchy, papules and vesicles over the normal or red skin, and tiny groups of blisters will be seen. Usually they are clustered, and due to sort of intense itching, they are broken by the time they come to see us. So sometimes again it is mistaken as scabies, papulotic area, etc. at the initial stage. So they will leave post-inflammatory hyperpigmentation and hyperpigmentation. In this picture, you can see the tiny vesicles with the erythematous background over the elbow. And again, all the lesions have been broken off with the scratching over the elbows, extensor areas. The skin biopsy will be supportive subepidermal blister with neutrophils mainly, and in immunofluorescence it will be IgA demonstrated with over the dermal papillae. There is not the uniform deposit, but over the dermal papillae. So the advice given to patients are gluten-free diet. Then dapsone is commonly used because neutrophils are acting predominantly. In potent topical steroids as well as systemic steroids can be used. So now we will discuss few things about epidermolysis bullosa. So now we are moving to from immunobullous diseases to mechanobullous diseases. This is a group of inherited diseases characterized by blistering in the skin and the mucous membrane. It may occur anywhere on the body, but commonly appear at sites of friction and minor trauma. So that is an important feature. Some subtypes, the blisters may occur in internal organs such as esophagus, stomach, respiratory tract, and also the lower GI without any apparent friction. So this results from genetic defects of the molecules which we discussed already. So in epidermolysis bullosa, there are three main categories. Epidermolysis bullosa simplex, simple version. That is, the blistering is in the epidermis. So the keratin is the defective protein structure here. So it is contained in epidermis, and the blisters are not damaged in the basement membrane, so there is less scarring. But in severe forms, patients may not survive, but the other forms, they are, relatively milder disease. In junctional, so as the word means, it is between the junction. It is in the junction between the epidermis and the dermis. So lamina lucida is one layer in the basement membrane. The other defective protein is there. Then dystrophic, the further deeper one, epidermolysis bullosa dystrophica, is due to lamina densa and upper dermal protein damage. So Kindler syndrome can present with mixed patterns, the blistering occurring in all these areas. So within these subcategories, you get further different variants. There are so many described, and they are being described further and further. The more the scientists find different molecules in this region. So degree of severity range from mild to severe. International, so this is regarding something, the nomenclature. So in autosomal dominant, so it is inherited one. So in autosomal dominant groups, now in each category you may get autosomal dominant and autosomal recessive groups. So in autosomal dominant variants, only one abnormal gene is needed. The advantage is, so there will be clinical phenotypic appearance, but still there is a normal gene in that patient, so that the disease severity may be less. But in autosomal recessive, you need both genes to be damaged. So one from each parent, father and mother. So then only the phenotypic appearance occurs. But if phenotypically affected, that means they don't have a normal gene. So the disease severity will be more. Usually, this epidermolysis bullosa blistering is seen at the early part of life, just after birth or in the neonatal period. But there are occasions where the disease may take years to appear in some cases. So males and females are equally affected because they are involved in the as autosomal dominant or recessive form, not as sex linked. So this is a child. You can see like exposed dermis over here. There's a thin like cellophane-like film, but otherwise the epidermis is not there, and a large area. This is the area where they have friction in the intrauterine light. And here again a large blister in the of a toddler in the feet, again where the trauma is occurring more. Then how can we manage these patients? Now, there is no permanent cure for these genetic microbullous diseases. So they have to avoid activities that induce friction on the skin. For example, maintain cool environment and avoid heating just to sort of avoid friction in the flexural areas. Use foam padding to help damage by hitting against hard surfaces like furniture, beds, chairs, and car seats, etc. So you have to choose clothing without any seams and very soft clothing. Footwear should be special and should avoid zips, etc. And when there are blisters, we have to pierce and drain them and let it collapse, which will promote healing. And we have to use certain resins which maintains the moisture. So there may be advanced wound care products which are low-headed because we can't use plasters on them. So when you remove the plaster, then again that area will be damaged. So there are certain low-adherent tapes or other dressings. So sometimes we apply a lot of lubricants to the skin to help reduce the friction. And when it is involved in the GI tract, we have to advise for a soft diet and use stool softeners, etc. And there are further newer treatments, but none of them are available in Sri Lanka, and actually none of them are available in even in the developed countries as routine therapies. So still the scientists are going on doing these experiments, but sometimes by the time you all are at my age, so these may be the normal treatment measures taken for epidermolysis bullosa. So that is gene therapy. So if you can correct the defect, the gene, then that will be curative. Sometimes editing certain defective genes. Then if you can't correct the gene, then if we can correct the protein which is defective, which we can administer to the patient, so that also will be helpful. And sometimes treating cells which may be able to produce normal molecules in these patients. So like treating with fibroblasts, stromal cells, then bone marrow stem cells, bone marrow and the other pluripotent stem cells being administered to the wounds so that they will take over to produce normal molecules and cover the defect. So there is a natural gene therapy. So that has been observed over the years where these patients who have the genetic defect can reverse their genetic defect. So that is called revertant mosaicism. Now, you know, when the cells are going on dividing, they get this genetic damage. So likewise, the damaged genes, when they go on dividing, duplicating, they automatically correct their defects. So that is called revertant mosaicism. Revertant mosaicism, where we see naturally the disease severity goes down. So now, so in the coming about 20 minutes time, I will talk about the pigmentary disorders. Then again, there are so many pigmentary disorders on the skin. Common, uncommon ones. But I think due to lack of time, we will talk on basic principles on that. So the melanocytes are located at the base of the epidermis. So we know it is in the basal layer. So melanin produced by melanocytes is transferred to the keratinocytes by these dendrites of the melanocytes. So the melanocytes of dark-skinned people produce more melanin or more melanosomes than those of people with lighter skin. But both groups, the white people and the dark people, both have same number of melanocytes, but the melanin production is more in darker people. So there is more melanin produced when the skin is injured, like say following exposure to ultraviolet light radiation or wound etc. So melaninization process in dark skin is protective against sun damage. So now we are living in a tropical country. All throughout the year, we have sunlight, ultraviolet light from 6 a.m. to 6 p.m. So that is an adaptation for the living in a tropical country. Actually, when you consider the evolution, the first man had been a darker skinned man, and who migrated to colder climates have changed their color to lighter skin. So, I mean, when we consider about physiological causes of pigmentation, sometimes friction, etc., can cause pigmentation. The one common example is hormonal effect of estrogen during pregnancy. During pregnancy, or sometimes the certain medications can again cause pigmentation over the nipples, vulva, and abdomen. So on the abdomen, we call it linea nigra. Nigra is the dark color. So pigment demarcation lines are natural lines where there is a sudden pigment change on the skin. So sometimes even any of us can have such lines. They can occur over the face or sometimes commonly over the arms. So this is an example. You can see there is a darker skin area abruptly changing into lighter skin. So that is in the genetic development, there had been a slightly different two cell lines. So disorders causing generalized the pathological pigmental changes can be hyperpigmentation or hypopigmentation or complete absence of skin color, like in vitiligo. So in hyperpigmentation, there is increased color. Hypopigmentation, there is reduced color, but still there may be some color in hypopigmentation. When we consider the hyperpigmentation, it may be generalized or localized. Hypo, again, generalized or localized. So in generalized hyperpigmentation, it may be due to excessive circulating melanocyte stimulating hormone, melanocyte stimulating hormone. So this will give often a bronze or brownish dark color. Examples are patients with Addison's disease will have increased color in all over the body, but especially the color increase will be seen in pressure areas, skin folds, on scars, and also the oral mucosal involvement. So in Addison's, primary adrenal failure, make a point to look into the oral cavity whether there is pigmentation if you suspect a patient. Patients with hemochromatosis, a disorder in iron deposition, will in about 90% will have more pigment, especially over the genitals and skin folds and sun exposed sites. Rarely metastatic melanoma can cause generalized increased pigmentation, and sometimes certain drugs may cause hyperpigmentation. Then localized hyperpigmentation can be sort of benign overgrowths of cells like melanocytic nevi, seborrheic keratosis, and lentigos. There is increased melanocytes in the localized cells. It can cause localized hyperpigmentation. Those melanomas and pigment usually not pigmented, but there is a variant called pigment basal cell carcinoma. So both of them will look very dark color. So then post-inflammatory pigmentation due to prior injury or current or prior inflammatory skin diseases such as eczemas, especially in dark skin individuals, and fixed drug eruptions. So fixed drug eruptions are where there is a fixed area where all the time when the patient uses the drug will cause pigmentation. So that will have a particular violaceous color. Current or previous superficial skin infections, particularly pityriasis versicolor and erythema. So those are pityriasis versicolor usually cause hypopigmentation, but there are variants where they have hyperpigmentation, and also erythema can cause hyperpigmentation. Erythema is due to corynebacterium infection in the commonly in the axilla. The localized hyperpigmentation, now one common condition is melasma, facial pigmentation over the cheeks. It is much more common in females in middle age. Maybe about 30% of females in this age group are affected at least with a small patch of melasma. Then photodermatitis due to certain plants can cause pigmentation. Thickened skin may present as pigmentation. Acanthosis nigricans commonly associated with obesity and sometimes with malignancy, and sometimes ichthyosis. Different causes of ichthyosis are there. Ichthyosis may present as increased pigmentation. So there are localized pigmented patches in pigmented purpura. Now, as the word means, purpura is bleeding into the skin. So in capillaritis, where the inflammation of capillaries is there, damage and causing leakage of cells. So the hemoglobin will be retained there, then hemosiderin, which will give rise to pigmentation. So senile purpura, that is, elderly people can have due to lack of collagen support, bleeding, sometimes venous stasis in the legs can cause long-term retention of hemosiderin, giving rise to pigmentation, and even after sclerotherapy. So now look at this patient and see what has happened. She has hyperpigmentation over the cheeks, so the one which I described you, that melasma, and there are hypopigmented macules. That is due to probably bleaching agents which she has used as a treatment for melasma, causing over bleaching, leading to hypopigmented patches as well. Then treatment. Now actually treatment will depend on the cause for the pigmentation, but generally sunscreens or sun protective measures, not only sunscreen, carrying an umbrella, wearing a hat or a cap, covering with a cloth, etc. So there are so many measures which we can take to protect ourselves from sun damage. That will be very helpful in treating hyperpigmented disorders. Hydroquinone again will bleach or reduce melanin synthesis in the area. We have 2 and 4% topical preparations. Then topical retinoids will enhance cell turnover and cause light color. Then topical corticosteroids can affect the melanin synthesis and reduce the color, but a special mention, now this topical corticosteroids is being misused by people, general population, by beauticians and quacks, and sometimes even by the qualified medical practitioners, but that should not be done. So there are many, irreversible side effects of prolonged corticosteroid use. Then glycolic acid and other fruit acids which will peel off the skin can be used. Acylic acid will reduce melanin synthesis. Vitamin C again has antioxidant effect and lighten the skin color. So there are various other procedures where we can use chemical peeling. We apply a chemical, allow the skin to peel off, causing a light color. And there are certain lasers which we can apply to the skin, certain procedures like dermabrasion, etc. So those are the procedures where we can help patients depending on the etiology and the site of the hyperpigmentation. Now we'll move on to the reduction in pigmentation. So congenital forms may be racial in origin or genetic, or due to albinism, where the tyrosine is defective. It's a genetic defect and causing light color all over, including the iris. Now, in acquired conditions like pituitary failure, pituitary secretes a message stimulating hormone, melanocyte stimulating hormone. So that is a message. So that may be reduced in pituitary failure, which will give rise to acquired generalized hypomelanosis. Sometimes same can happen with hypothyroidism to a certain extent. So, pallor can occur due to blood loss as well. Now, our skin, the color is contributed by mainly melanin, but the fat and the blood underneath also contribute. So, somebody who has lost blood quickly will be pale in color. Localized hyperpigmentation. So, there are so many causes for this as well. So, congenital parabolism, and where there is a defect in melanin production and melanin transfer. So, these conditions like Waardenburg syndrome, deafness. So, they will be congenitally by birth, they will have depigmented patches. Then there are like lowest in the list, achromic nevi, where there is less pigmentation. So that is again a genetic difference. So you have the normal genes required for the normal pigmentation. In this particular area, there are keratinocytes, which the melanocytes has less melanin producing genes. So that there will be a well demarcated area with light color. So that is again is not an uncommon condition. Sometimes patients do not present, but they know that it is a birthmark. So pityriasis alba, we discussed yesterday, that causes light color patches ill-defined due to dryness, sun exposure, and mild dermatitis. Idiopathic guttate hypomelanosis, idiopathic guttate leukoderma, that is common in middle-aged or a little bit elderly females with commonly in females, tiny depigmented spots which look like vitiligo, but they don't spread like vitiligo. So sometimes patients come in panic thinking that it is vitiligo, but you can assure that they won't spread, but they won't go off either. So there will be maybe 10-15 tiny depigmented dots. So progressive macular hypomelanosis is common in middle age or probably the younger age group, maybe just after teenage to 30s. Over the back, sometimes it may come over to the abdominal area as well. They look like hypopigmented patches, ill-defined hypopigmented patches, which can be confluent over the back. So sometimes they respond to treatment similar to acne treatment. Then inflammation can cause hyper as well as hypopigmentation, or the scarring it may be a cause. Then vitiligo is where autoimmune damage directly damages the melanocytes. So no melanin at all over the lesions. Lichen sclerosis, again autoimmune destruction in the basal layer, can have light color patches. Leprosy, we don't know the exact reason, but can cause hypopigmented anesthetic patches. Hypopigmented anesthetic patches. So this is a patient with pityriasis alba, which we saw yesterday as well. And the therapy. Now I think vitiligo you have seen, in normal life as well, because it is so common. About 1 to 2% of the population has vitiligo. It is, something all of us have seen, a well demarcated area of depigmentation, and commonly it is affecting the extremities and the lips. So then we call acrofacial vitiligo. Sometimes can be segmental. So vitiligo can have associations with other autoimmune diseases, because this is again an autoimmune disease, autoimmune damage to the melanocytes. So the treatment, the hyperpigmentation due to inflammatory skin disorders and infections usually resolve by themselves over weeks to months once the underlying disorder has been corrected. So there is no effective treatment for acromia due to previous scarring or achromic nevus. So the vitiligo is one of the conditions which we try to treat, but the treatment outcome is highly variable. Highly variable. So few things about vitiligo treatment. We have to protect the skin from trauma because vitiligo and certain other conditions like psoriasis, lichen planus has a phenomenon called Koebner phenomenon, where it occurs over the trauma sites. So vitiligo has that feature, so we have to protect skin from trauma to avoid further spread. And sun protection is important because that area has no melanin, so they can have sunburns, and long-term sun exposure can lead to skin cancers. So those problems should be addressed. Cosmetic camouflage. Now, if we can't treat them medically, we camouflage them. We hide the vitiligo with a sort of like cosmetic product like thing, which they can apply early morning. So full day, they can behave like somebody who do not have vitiligo. So the treatment, the specific medical treatments, they start with topical corticosteroids, topical calcineurin inhibitors. Sometimes we combine like tacrolimus, steroids and tacrolimus. Phototherapy, ultraviolet A, ultraviolet B, to suppress the autoimmune damage as well as to stimulate the melanocytes. Then in acute, rapidly spreading, very distressful situations, we use systemic steroids as well as methotrexate may be used in these patients. Now, we have certain surgical measures. When vitiligo, with the medical treatment, we can't clear them 100%. Sometimes we arrest the progress, then gradually improve to a certain extent, but they will be left with certain patches. So when the disease activity is not there, when it is not spreading, but still when they are not healing, then we can go for these surgical measures like punch grafting. That is, we take tiny punch skin pieces from the normal area and graft them in the vitiligo area. So gradually the melanocytes will spread to the surrounding area and get the area pigmented. Similarly, we can use epidermis caused by blisters. Sometimes we apply suction on this normal skin and make it to form a blister, and then take the roof of the blister and graft over the vitiligo patch after dermabrasion. We abrade that area, damage the skin, and attach the donor epidermis. So then, similarly, skin grafting can be done. Then cultured melanocytes can be used. Sometimes they are non-cultured melanocytes. We just take from the normal area, certain melanocytes and keratinocytes, and separate them and apply them back to the vitiligo patch. So those are surgical measures where we can perform for vitiligo. So that comes to the end of my presentation. The